Hi, everyone. On today's podcast, we're going to talk about the updated evidence on induction for gestational diabetes. Hi, everyone. I'm so excited to welcome you to today's episode of the Evidence-Based Birth Podcast, where we're going to talk all about the evidence on being induced for gestational diabetes. My co-host for today is Dr. Morgan Richardson Cayama, and I'm so excited that we're going to be talking together about this important topic that we get questions about all the time. And just as a side note, you will be able to access all of the information from this podcast, including scientific references, our updated full-length signature article that's been peer-reviewed, as well as a free 2-page handout about the evidence on inducing for diabetes by visiting ebbirth.com/inducing-GDM. Also, as a content note, we will be talking about serious health issues and complications related to gestational diabetes. So today, my co-host is Dr. Morgan. She has her PhD and master's in public health and is a research associate here at Evidence-Based Birth. Dr. Morgan Richardson Cayama recently joined us in episode 370, where we reviewed the updated evidence on diagnosing gestational diabetes. And today she's back with us here to talk about what she found around being induced if you've been diagnosed with gestational diabetes. So Morgan, we're so happy to have you back.
Thanks again. Yeah, I'm excited to be back and talk more about the research on gestational diabetes. And like you said, I know this topic touches a lot of families, and induction is something we commonly hear about at EBB.
Yeah. So again, a quick refresher about Dr. Morgan's work. She's been on Team EBB for about 2 years now, and there's quite a few episodes you can go back to learn more about related subjects. So she taught all about the ARRIVE trial and elective induction at 39 weeks in episode 334. In episode 343, she talked about the evidence-based strategies for preventing a cesarean. In episode 369, she talked about preventing mistreatment in childbirth through her dissertation research. And the other big project she's working on is for about the past year, we've been working together to update all of the evidence we've published on gestational diabetes, also known as GDM for gestational diabetes mellitus. And we originally published here at EBB the evidence on being induced for gestational diabetes back in 2012. And then it was updated in 2019. And so since that time, a few more studies have come out about whether or not you should be induced for GDM. And we're excited to bring you some of this newer research. But if you haven't already listened to it, I highly recommend checking out the accompanying podcast, episode 370, all about the evidence on diagnosing GDM. You can find the podcast and the full-length signature article at ebbirth.com/diagnosing-GDM. So that gives you a lot more background information on what gestational diabetes is, the health risks, and why it's important to be screened for it, and the evidence on the different methods for screening and diagnosis, including alternative screening methods. And then another topic you might want to educate yourself more about is the topic of big babies that has a little bit of overlap with gestational diabetes. And you can find more information about that in episode 190. We'll put all of these links in the show notes. So for today, we're going to be talking about 2 common questions we often hear from parents who've been diagnosed with gestational diabetes. The first, most popular question we get is, should labor be induced if I've been diagnosed with gestational diabetes? And the second question that follows that, if I choose to be induced, when should that induction occur? So as you're going to see throughout this episode, there are no really clear-cut answers, and there's still some gaps in the research. So let's dive in. So Dr. Morgan, can you give us a quick refresher on gestational diabetes and tell us how common is it to be induced if you have this diagnosis?
Yeah, absolutely. So as you said, gestational diabetes mellitus, often referred to as GDM, is high blood sugar that develops during pregnancy. It's different from type 1 and type 2 diabetes, and the cutoffs or the diagnostic thresholds for blood sugar levels are actually lower for gestational diabetes compared to type 1 diabetes. And the reason that we screen for GDM is because it can lead to issues like preeclampsia, preterm birth, low blood sugar in the baby, and newborn intensive care unit admission or NICU admission. But with proper high blood sugar management and treatment, we can lower the risk of these issues occurring. So that's why, again, it is important to be screened for it and to be treated or have it managed if it does appear to be an issue. And people with GDM are also at increased risk for fetal microsomia or having a big baby, which is often defined as a baby weighing more than 4,000 grams or more than 8 pounds, 13 ounces. And they're also at higher risk of their baby experiencing shoulder dystocia or getting their shoulder stuck during labor and birth, even if the baby isn't big. So again, that's also why we recommend checking out some of the big baby materials and resources that we have at EBB, again, because these topics do closely align. But because of these higher risks, that means that some care providers are even more likely to recommend an induction before 40 weeks for someone with GDM. Some providers might also be more likely to recommend a cesarean if they suspect a big baby specifically, even if we can't accurately estimate the baby's size. And I know we've talked at EBB a bit before about how ultrasounds only have about a 50% success rate at correctly identifying a big baby, although this is slightly better at predicting big babies in the cases of GDM. So again, check out those big baby resources at ebbbirth.com/bigbaby and that podcast episode 190 if you're curious to learn a little bit more about that research. But because of all this, we do see higher rates of induction in people with GDM. Studies suggest that anywhere from 20 to 40% or more of people who are diagnosed with gestational diabetes get induced or receive an induction. So for example, in Sweden, where induction isn't really common, a large study found that about 21% of people with GDM are induced compared to only about 10% of people who don't have GDM. And we don't really have great data on induction here in the US for a few different reasons. It's just not really captured accurately. But induction rates are generally higher here overall. They're at least around 30 to 40% or more, depending on where you are regionally and who your care provider is. But it's likely that people with GDM here in the US are being induced at even higher rates than what we see in some of this international data. So even though it does seem like many people with GDM are being induced, we wanted to look further at the evidence to see, is induction always recommended or is it always beneficial? And do you want to talk more about this, Rebecca, and maybe touch on some of the challenges that we came across while we were reviewing this evidence?
Yeah, so I think one of the challenges we face is one you've already talked about, and that we can't really find accurate statistics on how often people with GDM are being induced, which is a little frustrating because it's hard to talk about a problem if you can't define the problem. But we do know that we're hearing from birth workers in many places around the world, but especially in the United States, that induction is commonly recommended and sometimes even suggested that it's required for people with gestational diabetes. And because there are documented higher risks with pregnancy complications with gestational diabetes, it makes sense that we have more care providers encouraging everyone with GDM to plan to give birth earlier. So usually through an elective induction at or near term, so a little before or 40 weeks or by 40 weeks. On the other hand, we do see that some care providers are recommending induction on a case-by-case basis. And that recommendation usually depends on how well the blood sugars have been controlled throughout pregnancy. For example, if your blood sugars have been managed well, simply by changing your diet, watching what you eat, and exercising, and you're managing to keep your blood sugars in the appropriate range, then there's going to be less pressure to be induced early. However, if your blood sugars do require taking medications to keep them under control, or if your blood sugars are not well controlled at all, then you might be told you need to give birth even earlier, like at 38 or 39 weeks. But it's really important that we need to have evidence for these suggestions. What are the benefits? What are the risks of scheduling an earlier birth if you have GDM? So before I get into the research with you, I want to talk a little bit about kind of the state of the science on gestational diabetes induction and some of the limitations of the research. So one of the first things you need to know as a listener is that most of the research on this subject is going to compare being induced with expectant management. Expectant management is known as a wait and watch approach, which means you're waiting for labor to start on its own. So you're waiting for spontaneous labor is what we call that. But with expectant management, you still might choose to be induced later if you want an induction or if there are medical complications that call for an induction. So specifically, studies on the topic of induction for GDM are comparing health outcomes between people with GDM who are induced at different weeks of pregnancy that are at or near term. And then they're comparing those with people who received expectant management up until a certain time point. So as an example, maybe in one study, they are comparing people who were induced at 38 weeks, and they are compared with people who are not induced until the 39th week. In some of these studies, these people in the expectant management group might have given birth spontaneously during that week, or maybe they had an induction at the end of that week or went into spontaneous labor later. So this means that the research is complicated because it's really hard to lump all the studies together and come up with a conclusion because the different studies are studying different time points, which makes it slightly harder to tease out, like, is there a generic recommendation? Another one of the key challenges with the research on inducing for gestational diabetes is that there are very few high quality, rigorous studies. So there are not that many randomized controlled trials. Most of the evidence on this topic comes from observational studies. In an observational study, the researchers are simply observing what happens when labor is induced or when the patient had expectant management. These studies are still important to look at, but they're not as rigorous. And the groups are a little bit different because people who have an induction early or who choose expectant management might have slightly different baseline conditions, or there might be more complications in one group or another. And with a randomized trial, you're kind of controlling for that because it's like flipping a coin and everybody settles into the two groups that are roughly equal, like have similar health profiles in both groups. But when you're just observing what happens, the people that fall into the induction group and the expectant management group might be different to begin with. So that makes it trickier. Most of the studies also are not that large, so they don't have enough participants to look at the impact of induction or expectant management on rare health outcomes, such as stillbirth or newborn death. They also typically don't measure other factors that influence pregnancy and birth outcomes, like how well were the blood sugars controlled during pregnancy and what types of treatment were they receiving for their gestational diabetes. So they're not tracking some of that important info. Also, most of these studies are only looking at pregnancies where you're pregnant with a single head down baby with no serious health issues, so fairly healthy populations. So some of this data might not apply to people with complications. And in some of the studies that were observational, as I mentioned earlier, the groups were different at baseline. So to start, before they even gave birth, some of the induction group might have had a different profile than the expectant management group. Specifically, those who were induced earlier were more likely to be older in age, have a higher body mass index, require insulin treatment to manage their diabetes, and have hypertension or preeclampsia. So it makes sense that people with these health conditions were more likely to have an earlier induction. And a few studies tried to kind of account for these differences and isolate the impact of induction or expectant management, but those methods are not perfect. So because the research has all of these limitations, professional organizations like the American College of Obstetricians and Gynecologists acknowledge upfront that there really isn't enough high quality evidence to make a strong across the board recommendation around when birth should be timed with gestational diabetes. Now, they're still going to provide clinical guidance and recommendations, which we'll talk about later, but they're pretty transparent about the lack of strong evidence, and so are we. So that gives you all kind of a background about the challenges of looking at this research. So Morgan, can you now share with us, what you found specifically about the overall benefits and risks of induction versus expectant management? for GDM?
Yeah, of course. So in general, we do see different outcomes and risks really depending on that timing of birth that you kind of spoke about earlier too, as well as whether labor was induced or expectantly managed. So researchers have found that inductions carry different risks depending on that gestational age or the week of pregnancy at birth. So again, both of these things are really important when we're talking about the research. It's not just the timing, but then there's also this sort of induction compared to expectant management piece. And so looking at the timing of birth, the research frequently shows increased risks and poor health outcomes. So, kind of worse outcomes for birthing people with GDM and their babies when birth happens before 39 weeks and 0 days or after 41 weeks and 0 days. So there's really kind of that sweet spot the research sort of suggests of the ideal timing of birth being between 39 and 40 weeks. And so because of that, this is what many professional organizations recommend. So that they recommend that most people with GDM do give birth between 39 and 40 weeks, which can mean an induction of labor is recommended if labor hasn't started on its own by that time. And again, someone might be advised to give birth earlier if there are other complications or if their blood sugars are not well managed. So when comparing induction with expectant management, the research suggests some possible benefits to induction, but there is conflicting and sometimes inconsistent evidence, especially when we look at some of these specific outcomes or health issues. And so this is probably, again, why so many professional organizations are being pretty transparent and candid about, we just don't have a ton of strong evidence. And so we looked at what individual studies had found regarding the impact on the birthing person or the mother, and then on the impact on the baby. So I can just talk through some of what we found with these individual studies around the impact on the birthing person. So for birthing people, most studies that we came across found no differences in cesarean rates in people with GDM whose labors were either induced or expectantly managed, at least between 37 and 39 weeks. Once we get to 40 weeks and after 40 weeks, the evidence actually suggests that the risk for cesarean birth goes up kind of across the board for people with gestational diabetes, but that it might be higher or at least slightly higher for those who are induced. So that's definitely something to consider. And we can kind of speculate on why that might be. For one, continuing a pregnancy past 40 weeks does leave more time for potential complications to develop. It could also be that care providers are maybe more quick to recommend cesarean after 40 weeks because of those increased risks. They might also be less patient with labor progress, and they might be quicker to label an induction if an induction is done. They might also be less patient with labor progress, and they might also be quicker to label an induction as failed if an induction is done and then proceed to a cesarean. So that's just some reasons why we might see higher rates of cesareans, especially after 40 weeks for people with inductions. We also don't see differences in rates of instrumental vaginal birth, like with forceps or vacuum-assisted births, between people who are induced or expectantly managed with GDM. And we don't see any differences in maternal deaths or serious maternal complications. The only difference that we've seen really when looking at these individual studies is in the risk of severe perineal tears, which are third or fourth degree lacerations that occur between the vagina and anus during birth. There is some evidence that inductions might lower that risk of severe tears, but the findings from across these studies are really inconsistent again. Some showed no differences between induction and expected management, while some did show kind of at least a slight decreased risk for perineal tears. And so that's really what we found when we were looking specifically for birthing people or mothers. But do you want to talk about, Rebecca, what we found regarding the impact on babies between induction and expectant management?
Yeah. So several studies looked at the risk of having a big baby if you have gestational diabetes, which you defined earlier as a baby weighing at least 4,000 grams or 8 pounds, 13 ounces. And this research that we have on GDM suggests that the risk of your baby being born big is probably lower if you're induced compared to expectant management, which would make sense because there's less time for the baby to grow in utero, so they're less likely to grow larger. There was one meta-analysis where they combined multiple research studies. They found that those with GDM who were induced had a 1/3 to 1/2 lower chance of having a big baby. On the other hand, research on the risk of having a large for gestational age baby, it's a slightly different measurement, but it's defined as a baby weighing more than 90% of all other babies born at the same gestational age, suggests that there's no difference in large for gestational age babies when you're looking at induction and expectant management for GDM. When we're talking about serious health complications, so the research on the impact of induction versus expectant management suggests that the risks really depend on the timing of birth. So there are higher rates of infant health issues with GDM when the induction is done pretty early, before 39 weeks and 0 days. Once you get to 39 weeks, 0 days, up through 40 weeks, 6 days, studies showed really no difference in serious health issues or any lower risks with induction compared to expectant management. So either of those options, if you go into labor on your own, that's great. If you're induced, that's great. There's similar outcomes between 39 weeks, 0 days, and 40 weeks, 6 days with GDM. The research on the risk of stillbirth or perinatal death, which includes stillbirth and early newborn death, suggests that there's a possible lower risk of perinatal death when babies are born between 39 and 40 weeks, but higher risks of death when they are born earlier before 39 weeks. These lower risks were found in 2 studies, while other studies, including a meta-analysis, found no differences in the risk. So just to recap, some of the benefits of induction that the research on GDM suggests include a lower risk of having a severe perineal tear, a lower risk of having a big baby, and a lower risk of stillbirth or perinatal death with inductions between 39 weeks and 40 weeks. And induction also, some of the other kind of more intangible benefits include that it may be convenient for some families. It may help them accommodate scheduling needs for themselves or for loved ones or for their preferred care provider if they want a specific care provider to be present during the birth. On the other hand, if we look at the risks of induction with GDM, the risks include a higher risk of cesarean if you're being induced after 40 weeks, and a potentially higher risk of serious issues for the baby if you are being induced early before 39 weeks and 0 days. So if your provider is recommending a 37 or 38 week induction, we do know that there are higher health risks at those times for babies. And that's pretty much across the board. That's consistent with other populations that they've studied induction with. There's also a potentially higher risk of stillbirth or perinatal death if the induction occurs early before 39 weeks and 0 days, although this risk is very low overall because this is a very rare outcome. And other kind of more intangible risks or drawbacks to induction include that you tend to spend more time in labor, and you also will experience more medical interventions throughout your labor because inductions by their very nature include interventions. And because medically induced contractions may increase pain, it can make it more difficult to avoid pain medications if you are hoping to avoid pain medicine. So that's kind of an overview of the research on the benefits and risks of induction versus expectant management for gestational diabetes. And as you mentioned, and we're just going to keep hammering home, the timing does matter, the timing of the birth, and the risks and benefits kind of change depending on where you are at in your pregnancy. So Morgan, we've kind of given an overview of the research. And if you want details, we have tons of details in the full-length signature article where you can even go and look through kind of a summary of each study and what it found. But what are the professional organizations around the world saying about being induced for this reason?
Yeah, so again, because of that lack of strong evidence and so much of the inconsistency that we see across studies, the guidelines and practices do vary around the world. So in the United States, the American College of Obstetricians and Gynecologists, or ACOG, we mentioned earlier, provides recommendations that again depend on how well your blood sugar levels are controlled. For people whose blood sugar levels are adequately controlled with diet and exercise, they recommend expectant management up to 40 weeks and 6 days. So again, you can go almost all the way up to 41 weeks before they recommend that these people who can control or whose blood sugar levels are controlled with diet and exercise need to be induced. They really advise against an induction before 39 weeks for those people specifically as well. So again, probably citing some of those risks with, higher health issues for babies and that higher risk of stillbirth and perinatal death for babies before 39 weeks. they make that recommendation to not induce anyone whose blood sugar levels are controlled with diet and exercise before that 39-week mark. But in contrast, if you do need medication to help control your blood sugar levels, they recommend that you be induced or give birth sometime during that 39th week. So 39 weeks and 0 days up to 39 weeks and 6 days. And ACOG really states that there is no clear guidance on the timing of induction or birth for people whose blood sugar levels are not well controlled. They state that delivery between 37 and 38 weeks might be justified in these cases, maybe even earlier if there are other complications. But again, that risk is really sort of weighed with what we see of these other risks, especially again for babies born earlier. So that's really kind of an individual case-by-case basis, something that can be done if there are other complications present. Now, in the United Kingdom, the National Institute for Health and Care Excellence, or NICE, recommends that care providers offer induction to people with GDM who have not given birth by 40 weeks and 6 days. If there are other complications, they recommend an earlier elective birth, which could be either an induction or a cesarean, again, before 40 weeks and 6 days. They don't really tease out as much some of the other issues in terms of how well your blood sugar levels are controlled. There's this kind of more of just a blanket recommendation that someone with GDM give birth by 40 weeks and 6 days. Meanwhile, in Canada, the Society of Obstetricians and Gynecologists of Canada, or SOGC, recommends that pregnant people with GDM be offered an induction between 38 to 40 weeks. And that exact timing, again, depends on how well your blood sugar is controlled and if there are any other risk factors. So that's what we kind of see, at least from those big professional organizations around the world.
Yeah, so it seems like consistently across professional organizations, the recommendation is if you have GDM, it's ideal if you give birth before 41 weeks, whether it's through spontaneous labor or induction or even cesarean if needed, correct?
Yes, that's exactly right. Yeah, if I had to sum it up, it's recommendations pretty much consistent of give birth before 41 weeks.
And something else we cover in the full-length signature article at ebirth.com/inducing GDM are some of the most frequently asked questions that we get on this topic specifically. And so we're going to cover 2 of those FAQs, but you can find more of them at the full-length signature article. So one of the questions that I found really interesting and that we hear a lot at EBB is about extra fetal monitoring in the 3rd trimester if you've been diagnosed with GDM. And that's because people who are diagnosed with GDM often face additional testing and monitoring, particularly as their pregnancy gets closer to term. Now, the reason for this extra monitoring is because of the increased risk of complications and poor health outcomes with GDM around the time of birth. So extra monitoring and testing can include things like non-stress tests to check the baby's heart rate, Doppler ultrasounds to check the blood flow in the umbilical artery, and comprehensive ultrasounds to check amniotic fluids, the baby's growth, and their biophysical profile, like their breathing movements and their muscle tone. But there is no international consensus around extrafetal monitoring for gestational diabetes, and it can sometimes be controversial. Here in the US, ACOG states that extra monitoring is usually started around 32 weeks of pregnancy for those whose blood sugars are either not well controlled or they have to be controlled with diabetes medication. They also state that extra monitoring might not be necessary if your blood sugar is controlled with diet and exercise, because research does not strongly show any higher risk of stillbirth in that population. ACOG also does not provide specific guidance on which types of testing should specifically be done. Now, we do see that many care providers are recommending that all of their patients with GDM or gestational diabetes get an ultrasound sometime between the 36th week and the 39th week to estimate the baby's size. And some care providers report conducting regular non-stress tests and checking the amniotic fluid on patients with medication-controlled or poorly controlled blood sugar levels starting at 32 weeks. So in 2024, a group of researchers conducted an international review looking at 8 different guidelines and 17 different studies to develop their own recommendation on fetal surveillance, which is what we sometimes call extrafetal monitoring for people with GDM. Based on the existing evidence, they recommend ultrasounds to check fetal growth and amniotic fluid in everyone with diabetes, whether it's gestational or type 1 or type 2 diabetes, beginning between 28 and 32 weeks. And if these results are normal, they recommend repeating the measurement every 2 to 4 weeks just to check in. In cases of other complications or uncontrolled blood sugar levels, it seemed like most guidelines were recommending ultrasounds every 1 to 2 weeks. And if potential issues were identified in these ultrasounds, like the baby is growth restricted and not growing, or the opposite, they're a large for gestational age baby, then they recommend increasing fetal monitoring to twice a week. So this increased fetal monitoring could include checking the amniotic fluid levels, doing a Doppler ultrasound, and doing a non-stress test or a biophysical profile test. So as you can, I think the summary of the fetal monitoring in the third trimester with gestational diabetes is that it really depends on which guidelines your practitioner is following, how well your blood sugar has been controlled, and whether you're experiencing any other complications. So that's one of the FAQs. Another one that I think is really fascinating is how can someone handle if they're feeling pressure to be induced or to have other interventions during pregnancy and birth. So can you take that one, Dr. Morgan?
Yes, yeah, absolutely. And this is an issue that is really near and dear to my heart with my own interest in respectful maternity care. And so I just want to say that right off the bat, no matter what health issues you might be experiencing in your pregnancy, you always have the right to say yes or no to any intervention, including an induction. You also have the right to informed choice and consent and to ask questions and to have those questions answered with accurate, comprehensive, and unbiased information. So an induction can be both medically necessary and still violate patient rights when it is pushed on a patient without their complete information or without being given complete information or without their full informed consent. So that's just something that's very important to keep in mind is even if you are diagnosed with gestational diabetes, you still have the right to ask questions, to get additional information, and to make these decisions for yourself. And as we discussed, inductions carry both risks and benefits for people with gestational diabetes, and it's important to discuss these with your care provider. So in general, inductions can impact the delivery of care. As Rebecca mentioned earlier, they do come with more medical interventions just by their very nature, and that can impact how someone perceives their birth experience. Also keep in mind, as we talked about throughout this episode and throughout our conversation, that benefits and risks and timing of induction really depend on how well your blood sugar levels are managed and whether there are any other health issues or concerns. So we do see, again, those different benefits and risks depending on these different factors like blood sugar control, other complications, and then again, you still have the right to make decisions for yourself and speak with these things about reverse. Also keep in mind that benefits and risks and the timing of induction can depend on how well your blood sugar levels are managed and whether there are any other health issues or concerns. The research, again, suggests that inductions carry different benefits and risks at those different weeks of pregnancy, and you may want to consider those when you're talking with your care provider and, to decide what's best for you and your individual situation. So definitely something that's important to keep in mind as we've talked about over the course of today's episode. I also really recommend checking out some of the other podcast episodes that touch on rights during care and respectful maternity care. Again, the issue that is near and dear to my heart. That includes podcast episode number 338 on respectful maternity care, where we talk with Dr. Jessica Brumley, who is a certified nurse midwife and has some really great recommendations and discussion around respectful care, as well as EBB episode number 369, What is Mistreatment in Childbirth, where I talk more about pressure and consent and what we see in terms of mistreatment and even how you can help advocate for yourself if you find yourself in that situation. And we include a free 2-page handout on respectful care as part of that conversation as well.
Yeah, you can get that free handout at ebbirth.com/369. And Dr. Jessica Brumley is actually the keynote speaker at our upcoming conference where we're going to be focusing on respectful maternity care. So I'm really excited about that. And I thought of one more resource as you were speaking, and that is at EBB, we do have a pocket guide to labor induction. So whether you're interested in natural labor induction techniques to help prepare your cervix or try to get things kick-started before you need an actual medical induction, or if you are just interested more on the evidence on induction, the evidence on the different methods of induction, that's all covered in the pocket guide, and we'll link to that in the show notes as well. So I think this is a really interesting area of research. It impacts a lot of families. Gestational diabetes is like one of the most common complications or health conditions that you can be diagnosed with in pregnancy. So it affects a lot of families as they're navigating their diagnosis, they're planning their own labors and birth. And maybe for some people, it doesn't matter to them whether or not they're induced. But for other people, it's a big deal. It's a big question to ponder and talk with your provider about. So I think what I'd like to do to close this out is to kind of wrap up with our classic bottom line. What's the bottom line on inducing for gestational diabetes, so that you have takeaway points, and then hopefully you'll leave this conversation with just more concrete knowledge about the evidence on this topic. So one of the big takeaways is that we still don't have enough evidence. We don't have enough high quality studies. We don't have enough randomized trials to strongly make a recommendation as to whether you should be induced or not, and if so, at what time. And the research that we do have points to the fact that there are different sets of benefits and risks depending on the timing of birth, the week of pregnancy, and whether the birth was induced or expectantly managed. We do have evidence to suggest that there are higher risks of health problems for those with GDM and their babies when birth happens before 39 weeks, 0 days, or after 41 weeks and 0 days. However, the benefits and risks of induction and expectant management also look different depending on how well your blood sugar levels have been controlled throughout pregnancy. So someone whose blood sugar levels were well controlled with diet and exercise might not benefit as much from an earlier induction or birth, especially before 40 weeks. And so it really has to be an individualized decision and conversation with your healthcare provider about your unique situation. Studies have found no differences between induction and expectant management in most maternal health outcomes, including serious health issues or cesarean rates before 40 weeks. However, inductions after 40 weeks, so if you wait until after that 40-week time point, those inductions might carry a higher risk of cesarean birth compared to expectant management. For babies, research suggests that induction does lower the chances of having a big baby if you have GDM. Studies also generally show higher rates of health issues if babies are born before 39 weeks and 0 days, meaning that it's probably best to avoid an induction before that time point unless you or your baby have health issues or medical issues or blood sugar levels that are not controlled that would indicate an earlier induction could be needed. Studies also show a potentially lower risk of death in babies who are born between 39 weeks and 40 weeks, suggesting that an induction might be more beneficial if your labor has not yet started on its own by this time point. However, the overall risk of perinatal death is very low, and some studies have found no differences between induction and expectant management. I think the bottom line, the final takeaway point is that inductions carry both benefits and risks. And so the decision to induce or not should be based on your individual circumstances, like how well your blood sugar is controlled, any other potential health issues, and your values, preferences, and goals. And because the research isn't super strong, I think there is a lot of gray area in there for people to make different decisions. Like everybody has slightly different perspectives on induction versus expectant management. So again, I want to encourage you to go to our website to find the fully updated signature article and handout on inducing gestational diabetes. You can find that at ebbirth.com/inducing GDM. So we do have a free handout on this topic that you can download to take to a doctor's appointment or share with a client if they're facing this question of should I induce and when for gestational diabetes. And go and learn more about gestational diabetes and how it's diagnosed in episode 370. And we have some really good episodes on induction. So, a lot of people do choose induction. And to support those families, we have a variety of resources. There is the Pocket Guide to Labor Induction at EBB that I already spoke about. We also have some really great episodes. We have a podcast episode with Jen Anderson on Team EBB, That's number 367, where she talks about the latest trends in induction. And we also have guests from Partner to Decide, which is a website that has decision aids to help guide people in making decisions about induction. That's episode 257. Again, we have so many resources for you. So if you want to dive down a rabbit hole, or you just want to get that handout for free, you can find that in the show notes. And I also can't talk about gestational diabetes without recommending the book Real Food for Gestational Diabetes by Lily Nichols, who is a specialist in prenatal nutrition and gestational diabetes. It's a great resource for those who've been diagnosed with GDM and want to try and manage their blood sugar levels with diet. It is evidence-based, includes citations to the research articles she used to formulate her recommendations. And I have found that book to be really empowering, and the family and friends I share it with also feel empowered. Like they don't feel stuck. Like I've had this diagnosis now, I'm helpless, I can't do anything. You actually do have access to information. You can get empowered with information, and you do have choices, and it's your body. So we want to encourage you, if you're listening and you have gestational diabetes, you are not alone. Other people have been there too, and there are resources and choices for you. So we wish you all the best. Thanks everyone for joining us, and we'll see you next week. Bye.